Hello, Chris Camel, Bureau Chief of Rescue. This video is all about the new and improved 7th edition Martin County Fire Rescue medical protocols. It's an exciting time. A little over a year ago, the decision was made to streamline our protocols to make them more palatable and easier to learn. This was in response to field personnel expressing their concerns. Captain Mike Gardner volunteered to take this very in-depth project on, and he's outdone even himself. The format and visual presentation have changed significantly. The protocols are easier to read, more to the point, and have fewer educational sections within the content. The information is delivered in a more efficient manner, and they will be easier to absorb. During this process, however, we did identify some areas that needed to be updated. This training covers these changes. Included with this video is a PowerPoint document that contains the pages from the protocols being discussed. Please follow along. I'd like to thank all of our reviewers, those who worked on photography and artwork, and of course Dr. Mike Farrar for their tireless dedication to this project. Now I'd like to introduce Captain Mike Gardner. Mike?
Thank you, Chief Camel. I'm Captain Mike Gardner, EMS 2A shift. Some of the overall changes with new protocols. We have new heading and format style, so we have a larger font, increased spacing for easier reading. In the digital version of the protocols, we have hyperlinks between the protocols to allow access to reference protocols more easily. We've streamlined the verbiage. There are some specific treatment changes, but the majority of the treatments are the same. Some protocols were separated or combined as needed to add clarity in treatment. In protocols where pediatric treatment differs from the adult treatment by more than one or more interventions, a separate pediatric page was created for that protocol. For example, allergic reactions, respiratory distress, or cardiac emergencies. Updates to the general medical section included streamlining to the ALS and BLS standing orders protocols. BLS treatments and medication were added. Mandatory oxygenation listed for select patients. The GCS scale was moved to the BLS standards of care protocol. BGL and temperature parameters are listed. 12-lead and 3-lead general indications were added. IV/IO access guidelines are added. ALS medication dosing info for repeat dosing instructions. CPAP standards of care were added. And we added general indications for end-tidal CO2 monitoring. We also standardized the verbiage for continuous nebulizer. In the allergic reaction, we've removed Zantac as our H2 blocker and replaced it with Pepcid. The adult dose is 20 milligrams IV/IO over 2 minutes, and the pediatric dose is 0.25 milligrams per kilogram over 2 minutes. For our sedation, behavioral emergencies, and agitated delirium protocols, we've made some significant changes. The sedation protocol now just deals with procedural sedation and painful procedures. We removed the agitated delirium protocol and combined it with behavioral emergencies. Some other changes with behavioral emergencies. 2 crew members should accompany any psychiatric patient to the hospital for crew and patient safety. Whenever available, a female crew member should accompany a female patient to the hospital. We removed the MAD method of delivery for ketamine in combative patients as it was too much volume to push nasally. For emergency reactions in ketamine, Versed 2.5 milligrams is indicated. Our diabetic protocols, D10W is the official first-line medication over D50. D50 will just be a backorder alternative from this point forward. We've also deleted thiamine as it's no longer indicated, and we've added a glucometer error code box to the protocols for easy reference should you get those error codes on your glucometer. We've added info regarding diabetic insulin pumps and how to treat patients with those. And we've added glucagon, which is carried by EMS captains and Lifestar. Another protocol separation is where we've separated the dialysis emergencies and hyperkalemia. We did this because hyperkalemia can affect many more patients than just a dialysis patient, so we wanted to have it as its own standalone protocol. We added bicarb dilution for any pediatric patient under 1 year to 4.2%, and you'll see this referenced in any protocol where bicarb is given. We separated fluid resuscitation in medical and traumatic shock protocols, and we added push pressor epidrip for adult shock. We removed dopamine from our protocols as it has been replaced by push pressor epi. I'm going to go ahead and demonstrate how to mix a push pressor epi dose and a epidrip. What I'm going to demonstrate for you now is how to mix a Epi push pressor drip. Epi push pressor is a 1 to 100,000 concentration, as opposed to Epi IV, who would normally push, is a 1 to 10,000 concentration. Now, how do we get that concentration? We're going to dilute 1 milligram of Epi 1 to 10,000 in 9 mLs of normal saline. So what you'll need is a Epi prefill. If we don't have Epi prefill available, you're going to have to dilute this into a 1 to 10,000 concentration using your 1 milligram vial, which we've done in the past. You also need a 3-way stopcock and a saline flush. To start, expel 1 ml of saline out of the saline flush, so you only have 9 mLs remaining. You're going to use your stopcock as a transfer device and inject 1 ml of 1 to 10,000 epinephrine into your flush. Give it a mix, and we're going to administer 1 ml per minute for patients in refractory shock to IV fluid or patients with signs and symptoms of pulmonary edema who can't get fluid boluses. Administer 1 ml, get a blood pressure, reassess, administer another ml. In the protocols, we have the age-based maximum doses for Epi 1 to 100,000 push pressor listed. You can also refer to your HandTevi app as well. For adults, you'll give 1 ml a minute, and you can repeat this up to 30 mLs. So you can mix 3 of these push pressor doses and give it as needed. An option to that is to also mix an epinephrine drip and run it on your IV pump at 2 to 10 micrograms a minute. To do this, we simply take 1 milligram of Epi 1 to 1,000, and inject it into 100 mLs of D5W. Start at 2 micrograms a minute and titrate to effect. A new protocol that's been added is the non-allergic reaction protocol. This includes our previous dystonic reactions protocol, but we've also created a new protocol to deal with ACE inhibitor angioedema, as this is a life-threatening injury, and we now have a method to treat this condition. EMS captains in the Lifestar will start carrying a new medication called TXA, or tranexamic acid. Tranexamic acid is used typically for hemorrhagic shock to prevent internal bleeding. However, it also has effects that will reverse ACE inhibitor angioedema and reduce the chance of airway obstruction. In our OB/GYN protocols, we've made a few significant changes. The protocols are now separated into order of care, first dealing with the care of the mother, delivery procedures, delivery complications, and then care for the newborn, both normal delivery and a distressed newborn. One major change is we have removed the physician consult to treat preeclampsia with magnesium sulfate. When treating an eclamptic seizure with magnesium sulfate, we will now proceed to the seizure protocol if the patient does not improve after 2 minutes of the initial magnesium sulfate infusion. For Pitocin, we are going to change how we mix the drug. It's still going to be the same concentration, but instead of 40 units in a 1,000 bag, we're going to put 4 units in a 100 bag. I'll demonstrate that for you now. We're going to take our Pitocin syringe, which is 10 units in 1 ml. We're going to draw up 0.4 mLs, which will give us 4 units. We're going to inject it in our 100 mLs of D5W, and we'll run infusion over 1 hour, same rate as before. Further changes in our OB/GYN protocol. Routine bulb suctioning is no longer indicated post-delivery unless a significant airway obstruction is present. In addition to suctioning, meconium suctioning is only indicated for persistent respiratory distress or an obvious obstruction. The presence of meconium alone is no longer indication for meconium suctioning and intubation. Next, we're going to review changes to our pain management protocol. First is end-tidal CO2 monitoring. It is indicated in any adult patient if the patient becomes lethargic or obtunded after administration of narcotic medications. End-tidal monitoring will also be mandatory in pediatrics regardless of their mental status after administration of narcotic pain medication. For the elderly, we are also going to be reducing our starting dose of fentanyl to 25 to 50 micrograms. This applies to patients 70 years and older. The elderly population tends to metabolize fentanyl a little slower, and we have had several instances of crews pushing multiple doses of fentanyl to achieve pain management, only to have that patient become completely attunded in the emergency room. This move is for patient safety. Ketamine drips. EMS captains and lifestar medics have been using ketamine drips for management of severe pain on a trial basis and has proven to be very successful. Now all paramedics will be authorized to give ketamine drips for patients in severe pain, patients where fentanyl is contraindicated, or patients that are severely hypotensive. Another indication to consider for ketamine over fentanyl is a patient who may be a recovering narcotic addict. Ketamine will avoid administering a narcotic analgesic to these patients who are susceptible to addiction. I'm going to demonstrate for you how we're going to run a ketamine drip. Our dose for ketamine in a drip is going to be 50 milligrams in 100 mLs of D5W. What is important is that we use a micro drip, and we're going to run the micro drip wide open until we administer approximately 50 mLs or half of the bag, which will deliver 25 mics of ketamine. The reason for the drip is we avoid what's called emergency reactions, or also known as a K-hole, where the patient may become very anxious, may have a feeling of dissociated reality, and unpleasant hallucinations. Using a drip is actually very rapid onset and does go a long ways to prevent these emergency reactions. To mix a drip, I'm going to take my ketamine standard vial and drop 50 milligrams, which is a half ml. I'm going to insert it into my 100 mLs of D5W. I'm going to run this drip with a micro drip set, wide open, piggybacked onto an IV line of normal saline. I'm going to be continuously reassessing my patient for relief of pain or signs of dissociation or emergency reactions. After approximately half the bag has been administered, or 50 mLs, I'm going to reassess my patient for relief of pain or any unpleasant emergency reactions. If they're still in pain, I will continue infusion. After 15 minutes, we can repeat this infusion another time to administer a total dose of 100 milligrams of ketamine. We have found that the onset, even using an IV drip on a microdrip, is very rapid and the results are almost immediate. For procedural sedation, we've also made some changes. Again, end-tidal capnography is going to be mandatory for any patient that we're sedating for any reason. We've added a low-dose Versed for ketamine emergency reactions, which would be 2.5 milligrams. Again, as I talked about in the painful procedure guidelines, emergency reactions are the presence of a dissociation, hallucinations, or again, as we commonly know it, the K-hole. Ketamine for painful procedures is also changed. It is now going to be delivered in the same 100 ml drip as before for adults and pediatrics. At this time, I'd like to turn the rest of the presentation over to EMS Captain Jennifer Colton.
Thank you, Captain Gardner. I'm going to introduce myself. I'm Jennifer Colton, EMS Captain for A Shift. I've been a floater for the last year. I'm going to continue reviewing the protocols where Captain Gardner left off, starting with our neurological protocol. One of the big changes with our neuro protocols is going to be, first one is going to be in seizures. Versed is now going to be our first-line benzodiazepine instead of Ativan. The Ativan is known to have a slower onset and it lasts a lot longer. Versed is going to be a much faster onset and shorter duration. The next change in our neurological protocol is going to be our strokes. The big change there is going to be a new comprehensive transport criteria. It's going to be the FAST ED4 score or greater with the last known well of less than 24 hours. So there's not going to be any more greater than 3.5 hours and less than 24 hours for inclusion for comprehensive. Now, if it's a FAST ED greater than 4, and as long as it's less than 24 hours, that will mean that they get a flight to or ground transport to a comprehensive center. Also, we've added a list of blood thinners to the TPA exclusion box for your review to make it a little bit easier to recognize the generic and brand names of some common blood thinners. And there will also be a updated comprehensive center boundary map that's going to show you a little bit more of the updated lines, whether they go to Tradition Hospital or Jupiter or St. Mary's. That line's going to be right at Canner Highway. Anything north of Canner is now going to go to Tradition, or north of Cove Road is going to go to Tradition, and then anything south of that line will go ahead and go to Jupiter or St. Mary's, depending on the weather and Lifestar's choice. So next up, we're going to review any changes to our respiratory distress protocol. The first change that's a little bit bigger is just that we're combining the COPD and asthma protocol into something simpler. Instead of it being 2 separate protocols, it's now going to be 1, and just whatever's different. For example, the epi only applies to asthma. You'll see a part in that protocol that shows, epi only giving in asthma. And then we've also simplified the continuous nebulizer verbiage to make it simpler and easier for you to read. We've added CPAP information, which will be hyperlinked to your ALS standard of care in the beginning of the respiratory distress protocol. You'll be able to click on that and get you'll be able to review instantly the CPAP protocol, contraindications, indications if you'd like. Another update we've talked about is croup and epiglottitis. We've changed the treatment. We've also added a croup versus epiglottitis information box that'll help you determine whether the child's having an epiglottitis episode or if it's more croup. And we've added some treatment, nebulized saline for mild distress, which you take 9 mLs of nebulized saline if it's just a mild distress. If you think they're more moderate to severe respiratory distress, we'll go ahead and do epi 1 in 1,000 in the nebulizer, and you don't need to go ahead and add any saline to that. You just use that as is with 3 mLs of epi 1 in 1,000. Next change is going to be to our advanced airway management or RSI protocols. We've added a box to emphasize the importance of the priority of CO2 or capnography confirmation. We've also added airway backup plans and pre-intubation hyperoxygenation steps. We're really emphasizing the importance of CO2 capnography, and if we can't confirm the capnography, it's going to be important that at least 2 paramedics or an EMS captain and a paramedic go ahead and confirm that together, whether you have to stick the laryngoscope back in the mouth and see if you could visualize that the tube is in the trachea. But there's a lot more emphasis now on getting that capnography because that's the gold standard. So that's the big changes to our RSI protocol. So next protocol we'll go over some changes is our cardiac protocol, in particular cardiac arrest. We've now separated the adult and pediatric cardiac arrest protocols. We've gotten rid of the flow charts. Pediatric post-cardiac arrest will now get a dose of amiodarone, just as the same as we did with the adults. We're going to go ahead and give epi after a second shock and ventricular arrest in adults and pediatrics. We're getting rid of the 120, 200 joules for defib, and now we're just going to go directly to 200 joules, and then you could just shock continuously at 200 joules as needed. All medications will now be listed to be given every 3 to 5 minutes in cardiac arrest in both adult and pediatric algorithms. The cardiac arrest algorithms were deleted. They're now in a standard format. All patients will now receive bicarb if not given during cardiac arrest. So if you didn't give it, whether it's an adult or a pediatric cardiac arrest, you'll go ahead and give bicarb post cardiac arrest when you obtain ROSC if it wasn't given during the cardiac arrest. We've added cyanide poisoning and smoke inhalation to cardiac arrest special considerations. If you have a strong suspicion, you pulled somebody out of a fire, they're unconscious, they're in cardiac arrest, you'll have that added in there as something you might want to treat if they're in cardiac arrest. Another change to narrow complex tachycardia, we're not going to give any medications if it's Wolff-Parkinson's White, as long as they're in a stable condition. They don't have any complaints that would warrant any further treatment. And we've also added a new protocol, regularly really wide complex tachycardia. Next change is going to be our environmental section. The only change there is that CO poisoning and smoke inhalation moved to the toxicology section, where we thought it was more appropriate over the environmental section. Toxicology, we've added transport guidelines to the toxicology standing orders. We've added CO poisoning and smoke inhalation to the toxicology section. We've also added MAG and bicarb to hydrofluoric acid arrhythmia protocol. The MAG for the hydrofluoric acid arrhythmia is going to be 4 grams over 15 minutes. And your bicarb is going to be 50 milliequivalents. Calcium is going to be 1 gram IV push. We've added toxic chemical inhalation protocol. Next up, we're going to go over some changes to our trauma section. We've added to the standing orders March treatment priorities, which is going to be treating massive hemorrhage, airway, respiration, circulation, and hypothermia. It's going to be in place of ABCs. The studies show that that's antiquated, and now our biggest concern is going to be stopping the bleed any way you can with tourniquets, or Israeli bandages, pressure bandages. Then you're going to move on to your airway, determine if you could do an NPA and OPA if it's not contraindicated. Work on the airway, put them in a position, a recovery position or a jaw thrust. Respiration, see if they have a tension pneumo, something that we could correct, or a sucking chest wound, go ahead and place a vented occlusive dressing. And then we're going to move on to circulation, go ahead and check, see if they need pelvic splinting. That's where you're going to just try to stop bleeding, give whole blood or TXA if needed. And then hypothermia, something commonly forgotten. We want to make sure we keep that patient warm, cover them with blankets, shut the AC down in the rescue or the helicopter. So that's something new to our trauma section. We've added SMR, or spinal mobilization restriction, in penetrating trauma. If you think it could have hit their spine, an example would be a gunshot wound. You'd want to go ahead and use SMR in that patient. We've added abdominal injuries, treating open abdominal wound care. Also a change to our antibiotic administration. It's still going to be given only by Lifestar and EMS captains, but instead of Ancef, we've replaced it with Rocephin, which will still be 1 gram in 10 mLs over 2 minutes IV push. And it's got its own section that talks about antibiotics now. Next change is going to be crush injuries. So our crush injuries, we've added tourniquet use before removal. So if somebody's been crushed, if it's an extremity, whether it's a wrist, an arm, a leg, we want to go ahead and try to get tourniquets around those extremities to help prevent a release of any toxins into the body that could cause any kind of hyperkalemia. And we've also added treatment for hyperkalemia in crush injuries. Calcium gluconate was added to the protocol as well, if you see any EKG changes that would indicate hyperkalemia. All right, so there was some changes to our head injury protocol. One of the big changes is we've streamlined it, made it easier to go through. And also the biggest change is going to be transischemic acid, or TXA, which has been added. It's going to be used for traumatic head injuries with a GCS of less than 13, whether it's a pediatric or adult patient. That's also going to be used if a patient's hypotensive, if they present shocky. If you suspect like they're losing blood, you want to go ahead and give TXA. That could also be given with whole blood, or if you don't have whole blood, you don't have to give it at the same time, but you're going to want to give TXA. Another big thing is going to be our extremity injuries. The whole protocol has been enhanced, and it goes more in depth with how to treat patients that had an extremity amputation. And then the traumatic arrest updates were made to Lifestar Transports. We've been doing that for a while, but it's never been listed in the protocol, but now it'll be updated in there. And for right now, we're not going to go ahead and give blood on a witnessed cardiac arrest and fly them, but once we have blood back, we're going to resume that protocol, which hopefully will be soon. And that's any witnessed cardiac arrest by Martin County Fire Rescue personnel or Martin County SO. If we get Ross back and it was witnessed, we'll go ahead and fly them, have Lifestar apply the Lucas, and go ahead and give blood for when we resume the blood protocol. So those are the big changes to our head injuries, our trauma. Next up is going to be some changes with our procedures. The procedures have now been separated by category. For example, you have an airway section, medical administration section, trauma, etc. Basically, we've just made it more streamlined and easier to go through and find what you need quickly. Everything's hyperlinked, so when you click on that procedure, it automatically brings you to that section that you need. We've moved cognitive eval functions to procedure section. We've added the Lucas device, its indications, contraindications, use to the Lifestar section. We've went ahead and added the pit crew CPR procedure, revised our SMR procedure. We have also added finger thoracostomy for trained Lifestar personnel and EMS captains. Another thing we've changed, chest seal indications have been updated. It's a lot more in line now with the TCC, not brand specific. And we've added the pelvic splinting procedure to the procedural section. So some other changes have been in our policies. They're now in a standalone section instead of in the appendices. We've combined determination of death, death in the field, and death scene guidelines into a single policy. And we've also added taking a picture when you're on scene with a patient that has a valid DNRO that we're going to have you upload to ImageTrend upon pronouncement. We've combined non-patient determination, non-transport guidelines, and patient refusal into a single policy with the same intents but rewording made to make it easier to go through. Some changes that we've made along to our medications. We've currently added glucagon, which we have been doing for a while on the streets, but it's now in the protocol. We've replaced Ancef with Rocephin. We've replaced Zantac with Pepcid and removed dopamine, which our epi push pressure and epi drip will be replacing throughout the protocol. We've also removed thiamine, which is no longer indicated. We've moved the duodot and 2-PAM to the hazmat protocols. And then we've made some changes to our appendices section. We've added an IV drip chart, drug calculation formulas for your quick review. Hazmat protocols have been completely overhauled, includes a medication reference section to med specific just to hazmat. And all the educational info that was in the treatment sections has now been placed in the appendices for your review to make it easier to read through the protocols and find what you need quickly. We've removed the symbols from the approved abbreviation list since reports are no longer handwritten and all done on the computer. We've added community paramedic protocols and a revision list to log and track any future changes that we may have. All right, guys, well, that concludes our 7th edition protocol changes. I'd like to thank you guys for watching, and if you have any questions, you could reach out to any of your EMS captains or Chief Camel. We will be sending out a PowerPoint also for further review and coming around the stations for some hands-on training. Thank you.